thank Mark, thank everybody of you to have been here in these days. It has been my great pleasure to have coordinated this great and important meeting together with Mark, together with Nicholas Derwich, and every important meeting there is and exists because there are everybody. Thanks again to everybody. In this my pleasure, I had the like to organize a meeting to have space since to research, since going to the clinician around the rehabilitation, talking about the important topic again, the stigma. Final today, concluding with a focus on mood disorder and above all the mixed states. Martin, I know that Martin, Nicholas and Sandro and so on, all the other colleagues and friends know how much I like these topics, and I like very much to focus it, giving my contribution. Hopeful in the future we can see the results about the modality to help clinicians and to help colleagues to better do better improve diagnosis and treatment of mood disorder. You know, following my everybody of you follow my past lecture, know what is my kind of approach to mood disorder. I think that the mood disorder is the only spectrum of mood. Inside this, there is the instability. Inside is the depressive phase. The depressive phase is not a separate illness. The depression is not only for me, but only for Kiskel, Rimmer, actually also Marquez is introducing this approach. We have a full spectrum of the mood with several modalities of instability, and at the same time focusing on mixed states, the tensioness or the griefly of the patient, muscular tension, irritability, depression, instability, all fused and confused and mixed hour by hour, week by week. This is important because I am a clinician, I am not a researcher. My study, my presentation follow always my clinical experience. And the problem was how many tragedies we can see following this illness increasing day by day, increasing very often by iatrogenic problem, followed by incorrect treatment, incorrect diagnosis done, and incorrect treatment. The dysphoric component of the mood is quite frequent within all subtypes of the bipolar spectrum, approximately 30%. I published this study, I show you again, I already showed in past my presentation, but actual evidence is similar. I don't need to show again update for this percentage, because more than 400 patients we found that more than 30% included inside the mixed states group. All Professor Hiskel already started to talk about already marking past days, defined some years ago in 2006 that melancholia as defined today is more closely linked with the depressive and mixed phase of bipolar disorder. Given the high suicidality from many of these patients, the practice of treating them with antidepressant monotherapy needs re-evaluation. I think there is no one of us can comment this sentence of Professor Kiskel. Following this his scheme, this is the scheme of Kiskel. Inside them we can focus the mixed group. This one, the patient with protected pneumonia, he called the bipolar 2.5 depression superimposed on cyclotimic temperament. The other one, 3.5. Prominent mood swings occurring in the context of substance or alcohol use or abuse. The 4, depression superimposed on hyperactive temperament. The very most dangerous condition. You know that since several years I summarized, I mixed in my experience following my clinical activities and created a new scheme. Maybe it's more simplified to understand, but it is becoming from that of a key scale. Inside all the mood spectrum, I inserted the mania and the unipolar depression inside all subtypes, all types and subtypes of mood disorder, and the yellow one, other mood mixed states. On the left of the arrow, you can find the eventual developing of this basic diagnosis, or natural developing, or with incorrect treatment. Focusing on mixed group, there is cyclothymia, sometimes the cyclothymia when there is incorrect treatment or abuse of benzodiazepine, the mixed dysphoria. These are the main features of these characteristics. The agitated depression, the cyclothymic temperament, even if this is only a suppression and temperament, but it is also, for me, an important subtypes of mixed states. I show again, so you can see that the real percentage is pretty frequent in our practice. So that to catch, early catch, the symptoms of the mixity is very important, because the symptoms are the way that the clinician needs to take care of the patient, overlapping depression and mood and irritability, reduce the ability to concentrate and mental overactivity. This is very important, very difficult to catch sometimes. High internal and muscular tension, gastritis, colitis, dash, every kind of somatic symptoms, comorbidity with anxiety disorder, insomnia, disorder of appetite, a sense of despair and suicidalization, hyper or hyposexual activity, substance abuse, antisocial behavior, and also a case summarized some years ago. It presented here, you remember, 6 years ago in past edition of this congress, this slide, the symptoms of the mixity are anxiety and panic. There is not only panic disorder without any connection with the mixed states. The agitation, restlessness, grief, irritability, aggression, the impulsivity, and also I go on because I would like to focus also on an important, very, very important symptom of the mixity, the abuse of substance. Chronically, this conduct the patient to the so-called motivational syndrome, and making the patient resistant to treatment. Let me go back for just, okay. So that you can see that it's very important to catch the mixed states, understand, to go exactly the diagnosis, to prescribe exactly the treatment. The importance of premorbidity personality and the past history is essential to catch the real history of the illness of a patient. The temperaments are the basis of this way. They are continuous kind of presentation of the characteristics of mood peculiarities and some threshold form of bipolar spectrum. And it's a very important the sentence of Rimmer and Akiskal about the role of the temperaments, premorbid affective temperament types have an important role in the clinical